Good afternoon, everybody. Myself Rakhi Agrawal from Pune Hospital and Research Center, Pune. My topic is femoral nerve block in fracture neck of femur. Makes positioning of the patient for subarachnoid block easy. Femoral neck fracture causes very severe pain. Introduction: fracture neck of femur is common injury in elderly patient, incident about 2.5 to 5% at age group of 50 years, rising up to 20 to 50% in age group of 85 and above. Pain in fracture neck of femur is challenging to manage. Why? Because it is elderly patient, often frail, pre-existing comorbidity, altered pharmacokinetic and pharmacodynamic in this patient. They are on many medications, difficult communication because of confusion, hearing difficulties, etc. Management is treatment of fracture neck of femur is surgical fixation, that is stabilization of fracture as early as possible. For surgical anesthesia, neuraxial block is usually preferred. During neuraxial block required proper positioning of the patients. For neuraxial block, sitting or lateral position may be chosen, which requires flexion of the hip joint along with a spine. Optimal position is often difficult because of severe pain, as flexion of the hip joint is required. Inadequate positioning adds to the pre-existing technical difficulty in this elderly patient because of scoliosis, kyphosis, ankylosing spondylitis, etc. Options for managing pains are opioids, NSAIDs and femoral nerve blocks. Opioids has some side effects like respiratory depression, drowsiness, confusion, delirium, nausea, vomiting, which are more common in this elderly patient. NSAIDs has some side effects like platelet dysfunction, potentiate pre-existing renal impairment. 40% of these patients already have some kind of renal impairment and effect on gastric mucosa. Therefore, femoral nerve block may be a preferable option. Few studies are done on this. UNMG et al. In November 2009 compared the fascia iliaca block along with IV fentanyl, and he found that fascia iliaca block more efficient than IV fentanyl in terms of facilitating the lateral position for spinal anesthesia in elderly patient undergoing surgery for femoral neck fracture. And CP Gosavi from Bombay Hospital in April 2011 done the study on 40 patients using femoral nerve block. He found that femoral nerve block is safe, simple and effective in relieving pain and muscle spasm caused by fracture bone while positioning the patient. No systemic side effects were observed and hemodynamic stability was well maintained. Our study is efficacy of femoral nerve block in facilitating the patient positioning for subarachnoid block. Why femoral nerve block in fracture neck of femur? Pain of fracture neck of femur is mainly transmitted by femoral nerve. There is some contribution from obturator nerve and lateral cutaneous nerve of thigh. We randomly select the 60 patients of fracture neck of femur between the age group of 50 to 90 years. We divide into two groups. Group A is control group, 30 patients who receive only neuraxial block, and group B, that is femoral nerve block group, 30 patients who receive femoral nerve block prior to the subarachnoid block. We compare the pain score while positioning the patient for subarachnoid block using numerical rating pain scale. Landmark for giving femoral nerve blocks are we palpate for the anterior superior iliac spine and pubic tubercle, and line joining this is inguinal ligament, and midpoint of this we palpate for the femoral artery. Just 1 centimeter lateral to that we pierce using insulated 22 gauge needle and using peripheral nerve stimulator with a current of 1.5 milliampere at 1 Hz frequency, and watch for contraction of quadriceps and patellar tap. If this present, then we decrease the current up to 0.5 milliampere, and if still present, then we inject a drug using a mixture of 10 ml of 0.5% bupivacaine and 10 ml of 2% lidocaine with adrenaline. We use this combination because we want early onset and long duration of action. Then we watch for the dermatome anesthetize. This dermatome anesthetized by the femoral nerve. We using the needle we pierce the anterior medial sign and watch for the sensory blockade. Then we give sitting position to this patient after 15 minutes of femoral nerve block. Then we evaluate using numerical pain scale. Numerical pain scale is from 0 to 10, that is 0 that is no pain, to 10 that is unbearable pain. It is very simple to use in this elderly patient, that's why we choose a numerical rating pain scale. Results are in the form of while positioning the patient, numerical rating, mean value of numerical rating scale in group A is 8, that is control group having 8 numerical rating pain score. In control group B, that is femoral nerve block group, we get 1 value, that is highly significant with p value of less than 0.001. In this graph it shows the group A, that is control group, has the numerical rating pain scale of 8. 15 patient has numerical rating pain scale of 8, and group B, that is numerical rating pain score, about 13 patient has numerical rating pain score of 1 and 11 patient has numerical rating pain score of 0. Failure and complication. In our study with relation to femoral nerve block, we had no complication and 0 failure rate. Conclusion, we conclude that in patient with fracture neck of femur, femoral nerve block is effective in reducing pain of positioning the patient for subarachnoid block. It's also beneficial for the anesthesiologist as it allows better positioning for subarachnoid block. Take home message, every patient of fracture neck of femur should receive femoral nerve block prior to positioning for subarachnoid block for comfort of patient as well as anesthesiology. Thank you very much.
Have you calculated the total dose of the local anesthetic that you have given?
Yeah, we calculated. All patients are above 40 kg of it, so they are means this volume is adequate for, means this volume is not causing any toxic, not process the toxic level.
After that you have given the subarachnoid also, isn't it?
Yeah.
So have you calculated the total dose? Especially
yeah.
Because they are elderly individuals.
Yeah, we calculated, but they doesn't process the toxic level.
For your study protocol, the group that did not have femoral nerve block, what did they receive? Anything?
No, sir. We didn't
No.
use anything for them.
So isn't that a somewhat biased study? You already know the answer
yeah.
before you do the study. Should you not do what you usually do if you don't do a femoral nerve block? Give them some analgesic drugs or
Yeah, but our
fentanyl?
institution practices like we give femoral means directly give subarachnoid block in fracture neck of femur. We usually didn't give femoral nerve block. We just recently started with femoral nerve block. Started giving femoral nerve block in this patient.
The other suggestion I have to make is when you look at proximal femoral fractures, there is greater disruption of the periosteum with a trochanteric fracture when compared to a femoral neck fracture. So the incidence of pain with a femoral neck fracture is much lesser when compared to a trochanteric fracture. So taking on from what Professor Chan has told you, you could have used that as your second group.
Yeah, sir, but periosteum is mainly supplied by the femoral nerve, so we are chosen femoral nerve.
Was there any difference in the success rate of the subarachnoid block because the position could be given easily after giving the femoral
Yeah,
block?
means time required for struggling for giving subarachnoid block is much lesser.
That you
I
don't
didn't
seem to have
mention.
compared.
I didn't. Thank you very much.
We can just add on another person who will give spinal who doesn't know whether the femoral block is given or not.
Yeah, blind, double blind study.
Person.
Yeah, double double blind study. You.
This was third person who gives spinal.
Totally blind.